just to give you the outlines of my talk today, first I'm gonna just refresh you about the definition and roles of epidemiology in general, and then I will narrow it down to the roles of field epidemiology, specifically in global health security. And then I will give you like a brief description of how the WHO strategic preparedness and response during the COVID-19. And then I will go through some of the COVID-19 epidemiological studies that I led. And then I will explain to you about the lesson learned regarding the opportunities and the challenges that we face as epidemiologists. And then lastly, I will try to sum it up in one slide. Yeah, I just wanted to show that on the right side, I start this slides with the photo of this is actually the famous, pump water in Broadway Street in London, in central London. You must know that that the father of field epidemiologist is John Snow, who unrevealed, who revealed the mystery of the cholera outbreaks in London. It's now becomes a cafe, actually, a bar. So you can have people usually have a drink during Friday afternoon in London in this bar. So not really historical building, but you have the exact location of the pump handle here in the photo, but then the original one is kept in the museum. So as you may know that epidemiology is, the definition of epidemiology has evolved like through time to times. And I think the most complete definition of epidemiology is the study of the distribution and also the determinants of health-related status. So not only about infectious diseases, but all health-related status or events. It can be non-communicable diseases, it can be injury and other, or mental health and other health-related problems that we face nowadays. Of course, the epidemiology is used to know not only to determine the distribution and determinants of those problems, but also to find out how to apply this the epidemiological methodologies, the epidemiological science, to control the health problems especially in the population. Some said that epidemiology is a bit like a detective work. We as epidemiologists try to find out how and why certain diseases or health problem occurs, and we wanted to find out how to then control the problems. I took this summary of roles of epidemiology from the book called Essential Epidemiology from Webb and Bain. They are both, I think, experts in epidemiology from Australia. You can buy the book, or you can also find the PDF version of the book online. So as I mentioned before, that roles of epidemiology has evolved. So the first one is to investigate the cause of disease and modes of transmission. We want to know what causes the diseases and then how the disease actually transmitted to in the population. And then the second one is to determine the extent of disease problems in the community. So after we know the cause of the disease and modes of the transmission, we also want to know like how big the problem is in the community. And the third one will be to study the natural history and prognosis of diseases. This particularly very important when facing like the new emerging diseases, for example, like the new SARS-CoV-2 transmission that later caused the disease that we call COVID-19. So it is really the role of epidemiology is really important to know how the disease, the natural history and the prognosis of disease, so then we can then help clinician and also public health expert to develop a policy and intervention. And the fourth one is to evaluate both any existing and also new preventive and therapeutic measures and modes of healthcare delivery. For example, to evaluate, maybe new vaccines, also maybe to evaluate the existing vaccine or the existing program during the COVID-19, for example, maybe the lockdown, the PSBB, and others. And the last one is all of this data, all of data that we as epidemiologists, gather, generated, and also analyze and interpret, will be at the end to provide a foundation of developing public health policy and also regulatory decisions. The US CDC, the one that actually founded the Field Epidemiology Training Program, the program that is specifically aimed to train people, public health officers, to to have skill set to collect, analyze, and also interpret data, and then how to use the data to rapidly respond to the outbreaks or pandemic. So yeah, the roles of field epidemiology in global health security is actually really essential. For example, I took this from a report from the US CDC in 2021. This graph actually showed us how important the roles of field epidemiologists in global health securities. You can see here that our FETPs, the Field Epidemiology Training Program, field epidemiologists have actually played key roles in responding to major health threats from, for example, from Zika virus outbreak in the Americas region, Ebola virus diseases. We also have some epidemiologists, some experts from Indonesia who was sent to the Ebola outbreak location a couple years ago and then did some kind of sort of outbreak investigation and response work under the WHO consultation agreements. So yeah, people from Indonesia also played role in global health security. And others diseases like MERS-CoV, polio outbreaks, Nipah virus, and the latest one is that we are still facing now is the global pandemic of the novel coronavirus diseases 2019. This is a very complex graphs, I think. Basically outlines the pandemic preparedness and response from the WHO grand plan, which was available from 2021. You can see here that the preparedness and response for COVID-19 actually focuses on 4 main goals, which is one is to suppress the transmission, second, to reduce the exposure, the third one will be to protect the vulnerable people, and the fourth one will be to reduce the mortality and save lives during the COVID-19 pandemic. So each, if we relate this to the my previous slides regarding the roles of epidemiology, that epidemiology has a skill sets, to collect, analyze, interpret, and also form public health policy driven by the scientific evidence, then we can actually clearly see what is our roles in responding to the COVID-19 pandemic here. For example, for the first goal is to suppress the transmission. We can see that we epidemiologists have a key role in, for example, in detecting and then in doing the contact tracing, in trace the contacts, trace the cases, and then doing field investigation, and then how to, also determine who is, most vulnerable in the population. If they get sick, if they get infected by the SARS-CoV-2, then who are the most vulnerable one of dying of COVID-19 in the population. So I think the most relevant and essential role for epidemiology will be around transmission in this first goals of the preparedness. While for the other focuses, we may also play roles, but I think it will be more on social epidemiology, for example, in in developing methods on how to effectively, for example, how to effectively approach and engage with local community, how to effectively assess and also introduce a vaccine program in the community. And also for the fourth one, for reducing mortality, we also have a key roles on first detect identifying the most vulnerable group, and then second also to evaluate the most effective intervention that can be done to reduce mortality for those high risk population. So we at the OCRU, we are one of the Oxford University Clinical Research Unit, which is based in Indonesia. We focus our research on understanding the mortality and also the transmission dynamics of COVID-19 in Indonesia, in order to better to give evidence to the government in order to better target the public health intervention in the population. In the next couple of slides, I will share with you some of the research that I led, which have been published in several journals. You can later, I will share the slide, and then you can later just click the link, and then you can download the full papers. The first one is we did a study on clinical characteristic and mortality associated with COVID-19 in Jakarta in the early phase of the pandemic. Regarding the opportunities, I can say that this study actually very, very opportunistic, because at the moment we didn't really spend any money. We don't really have a specific fund to conduct this study. So it was just based on our close collaboration with this Jakarta Health Office, the Provincial Health Office of Jakarta. So we approached them. We approached the people from the Jakarta Health Offices, and then we offer them a proposal. We will help you identifying, the risk factors of mortality related to COVID-19 in your area in Jakarta. We will use the data that you, as as practitioner, as epidemiologists, as a public health workers, already collected during the field epidemiology investigation, and then we will help you with the science to then produce the findings. At that time, we simply wanted to know, because it's new diseases, we wanted to know whether the clinical characteristic and also risk factors associated with in-hospital mortality of COVID-19 in Jakarta is different or similar to those observed or reported in other settings, for example, in China, and also other setting in North America and Europe. I think this is also good for you, just to refresh you kind of type of epidemiological studies that we can use, and you can actually apply, for example, maybe for your thesis, or for your next your next work, or for your reference, for the next future outbreaks that might be occur in any days actually. We did the hospital-based retrospective cohorts in 55 hospitals in Jakarta during March 2nd to July 31st, 2020. We basically just collected all data that you guys, actually field epidemiologists or epidemiologists, collected in health facility, in puskesmas, in rumah sakit, and in dinas. So you already collected this data, and then we help them to do the analysis. We ended up analyzing around 4,265 cases, and then we compare, the mortality in Jakarta among those cases who were hospitalized with mortality rate in other countries like in the US and the UK. Again, this context was in the early phase of the outbreak, and we found that the mortality in Jakarta, 12%, is actually very low compared to mortality in the US and UK. You can see in the left side, US is 21% and UK 26%. And we think that the situation in the early phase of the COVID-19 reflects, why it is lower, because of in the early phase of the COVID-19 pandemic, more younger population were hospitalized in Jakarta, just to the panics, or just because we don't know what these diseases may impact our public health. So it seems like in the early COVID-19, we just hospitalize people with COVID-19, even though they are probably not really sick or probably just young. But unexpectedly, we found that actually the mortality among under 5 years old in Jakarta was surprisingly high. So we found it nearly 12% mortality among the under 5 years old children, which then become initial evidence for the government. Then the government respond to this finding by doing the audits, mortality audits among children, and they also then started to improve the care for children, because that we don't really have a good facility or care specifically for children at the moment. And this is just to show you basically what we found, that was factors associated with mortality of COVID-19 in Jakarta were actually quite similar with those observed globally, which was older age, more risk of mortality for male, and also more risk for those who had comorbidities, for example, hypertension, diabetes, and chronic kidney disease. And also the mortality is higher for those people who were admitted at hospital with clinical diagnosis of pneumonia, and also with those who were admitted at hospital in severe and critical condition. So they were directly admitted to ICU, and also directly gave immediate intubation. So the chance of surviving for those people were very, very low. I think this is if we relate this to the title of this presentation, opportunities and challenges. I mentioned earlier that the opportunities is that because we as epidemiologists have the skill sets to collect, analyze, and also interpret the data and form public health policy. And then so the opportunity is become automatically yours, because you are the only one who can do that, especially during the pandemic. So you are really valuable. You are gold in this pandemic situation. But then the limitation of our study also becomes challenges for you as epidemiologists doing research, or just as a professional epidemiologist trying to provide evidence to your boss or to your district health office or provincial health office. We found that there are quite high proportion of missing data, especially for some key baseline variables, for example, missing dates for symptom of onset, also for hospital admission and outcome, which is actually, maybe some people think COVID as not important because it's just a date, but then we as epidemiologists find it very important because without without the date of onset, date of outcome, date of admission, you then cannot calculate the time at risk, the person at risk. Then you cannot really calculate the the incidence rate or the incident risk ratio. So that's actually a basic science of epidemiology. But then when it comes to the real practice, I don't know, everyone seems to forget about it. So they didn't really collect those kind of very important data. So that's the main challenge. So the challenge for us is to, how to create the quality of data from the grassroots to the national level. Other thing is, well, mainly I think the most relevant one for us, for epidemiologists, is mainly about the missing data and then the quality of data and around the way how we do the field investigation, because sometimes people just didn't really do the field investigation. Then we found out that quite a lot of cases without any records of data in the district health office or in the provincial health office level. So from this, we found that, as I mentioned before, that risk factors associated with in-hospital mortality in Jakarta are similar to those in developed settings. The lower overall mortality in Jakarta was likely driven by the lower median of age of the hospital population, because as I said before, we just tend to hospitalize everyone without considering the age and other risk factors at that time. And then while children represented only 5% of hospital admission, but the 11% or nearly 12% mortality among children under 5 years old should prompt further investigation of them as potentially highly vulnerable in low middle income country setting, because we know in other settings in Indonesia we have problems with kematian pada anak, kematian pada bayi, what you call it, yeah, under 5 years old, all cause mortality. We have this kind of problem, and also we have infectious diseases problem, which usually infect children. For example, like soil transmitted helminths, filariasis, tuberculosis, and others, which also can then further put these under 5 years old children as a vulnerable group in Indonesia. What did I got? Masih berapa menit ya? Sorry.
30 menit.
Berapa menit?
30 menit, 30.
30. Oh, okay. Well, I still have 30 minutes. So yeah, basically, I just wanted to share like two of the recent the big research that we've done. And the next one is this is freshly accepted for publication in BMJ Global Health, British Medical Journal Global Health. So it is also about trying to understand not only the risk factors of COVID-19 mortality for individual, but also we wanted to know the risk of COVID-19 mortality for the community. In this case is district level, sub-district level, sorry, and then also the risk at the healthcare level. So we did the study also in Jakarta from March 2nd, 2020 to August 31st, 2021. So it covers the first 18 months of the pandemic in Jakarta. We analyzed individual level data. Against this data actually are the data that the district health office and the province health office already collected. So we only utilize the data. And then we also use the data, sub-district level data, for example, socio-demographics, number of population, the density, kepadatan, kemiskinan, poverty, and also health-related characteristic. All of these data were collected, from publicly available sources, for example, from BPS, also from the Ministry of Health report on Public Health Development Index, Indeks Pembangunan Kesehatan Masyarakat, and the other one is IPM, Indeks Pembangunan Manusia. So for the sub-district level data, we collected this kind of data from those data. So again, the opportunity for you is just like we did. We didn't have any funding for this, so we just collaborate with the because we are based in Jakarta, so we collaborated with Jakarta health offices and trying to help them to study the phenomena in Jakarta. Based on this study, we found that, so this study actually confirmed that not only for hospitalized patients, but also for general population, that the COVID-19 mortality is higher for, for older people and also for those who presented with one or more comorbidities. And interestingly, we also found out that, at the community level, COVID-19 actually, what do you call it? Maybe, yeah, the correct word is the disproportionately, but maybe this is not something very common for you, but we can say that COVID-19, didn't affect similar community in similar way. So some community affected more than other communities based on their high population density. So for people, for individual live in sub-district with higher population density, higher poverty, kemiskinan, and also lower vaccination coverage or rate at the time of this study, were actually more likely to die from COVID-19 compared to those with lower population density, lower poverty, and also higher vaccination coverage. We also found that actually we can, that actually the Jakarta Health Office did very well in reducing the mortality risk, especially among among children. Because if you see here in this graph, so each line represents the age group. So for example, blue is for group of under 5 years old, and then this one is 5 to 9 years old, the green is 10 to 19, and so on. So as you can see in here, the risk of mortality for example, for the blue one, for under 5 years old children, were high during the first, first maybe 3 or first years of the pandemic here, but then it rapidly decreased during the second wave of the pandemic. In here, you can see it. The mortality risk nearly get to 0 actually. So this is actually good. So again, the role of epidemiologists is not only to to determine the cause of the disease, to quantify how big the problem is, and then to identify the risk factors, but also to help the government evaluate how good they are in in responding to the pandemics. So this kind of study analyzing in analyzing the trend of diseases over time can also help the government in assessing their achievement. Again, if you look at the first limitation of the study, talking about the challenges, again, similar challenges appear in here, that actually because we are relying on routine surveillance data, that also mean that some some important variable were missing, or just simply were not there. They don't record it at all, and also because the reliance on routine surveillance also mean that we also rely our analysis, our study on the the imperfect contact tracing, imperfect testing due to low capacity of testing, also, low completeness, low, what you call it, timeliness of reporting activities. All of those, all of those variables could result in, underreporting of cases, especially for those asymptomatic and mild cases, because, uh, asymptomatic and mild cases tend to not get tested because of, they are mild and they are asymptomatic. So epidemiologically, this kind of limitation and challenges can then impact your result, can make our mortality rate or case fatality rate estimate become then over estimated, because we didn't detect mortality among those who are mild, who are asymptomatic, who are never get tested and reported by the government. So yeah, I think I can just jump for this one. I think the two key messages that I wanted to highlight from those two big studies, that one, as epidemiologists, we really need to, epidemiologists, one who is working on research, we don't really need big funding, big money to do a robust analysis and robust study. We can simply collaborate. So this is the opportunity for you guys. We can collaborate with the health office, or maybe you can start with smaller unit. You can collaborate with the health facility or puskesmas, or one or two puskesmas, or with one rumah sakit. Just offer them, I have the science, I want to help you, collect the data, analyze the data, interpret the data, and help you to, make or generate or formulate the public health policy. That's one of the, I think that's the easiest opportunity for you guys. And then the second one is the challenges. Of course, as epidemiologists, we also face the challenge of dealing with, missing data, unreliable data, low quality of data. But again, as epidemiologists, we have the science how to deal with the missing data. I think you can read, or you can have another course, I don't know, which specifically teach you on how to deal with missing data. So one opportunity is there because you have the science, you have the knowledge, you can simply offer the collaboration, or you can, or during the COVID-19, you can be the volunteers, or you can even also get paid for that. And the second one, the challenges is around the quality of the data. The last one that I wanted to share is the study that we conducted regarding mortality among healthcare workers. We actually struggle to find the data regarding mortality among healthcare workers. So the government at the moment, they don't have records of the population of the healthcare workers, and then how many of those healthcare workers actually get infected by the COVID-19, how many of those workers then died due to COVID-19. So the government don't really have that data at the moment. They don't have that database. So what we did in here is we tried to collaborate with Lapor COVID-19, which is a non-profit platform, NGOs platform to monitor the COVID-19 situation in Indonesia. So we collaborated with them, and then we collected data regarding cases of COVID-19 among healthcare workers, and also mortality among healthcare workers based on report in media. So we did content analysis. We keep watching on each district, on each province websites. We collect the data daily. It's really hard work actually, simply because of the current government. They don't have dedicated database to record the infection and mortality among the healthcare workers. So that's also another kind of opportunities for you epidemiologists, for us epidemiologists. outside of working together with the government, we can also collaborate with, with like the NGOs, non-profit organization, or you can just simply, if you can do it, you can just simply, collect the data from, from the news, but of course, systematically, also from other sources, for example, from website, for ED website maybe, atau website perhimpunan perawat, perhimpunan bidan, that sort of thing that you can actually do without costing you any rupiah. Actually, you just need internet connection and then you can browse. Here is the limitation. Again, we collaborated with Lapor COVID, and then we made what we call Pusara Digital Record. So we invited all people who has families or who has friends that are that were died due to COVID-19. So we invited them to report what is the name of their family, when did they die, what was the symptoms, and so on and so on. And then we basically just rely on those database to estimate the the mortality among healthcare workers. So because we only use this data, we found out that 30% of missing data on age, and also approximately 48%, nearly 50%, missing data on vaccination status. Also, the age and gender distribution of healthcare workers in Indonesia are not publicly available. So as I said before, the government don't have a dedicated website for this, so it's not publicly available. So consequently, we were not able to calculate the standardized age and gender mortality rate to improve the interpretation of this kind of data. I also led 2 ongoing studies, but I'm not going to go into details. One is about heterogeneity of COVID-19, an association between prevalence of comorbidity against another type of study that you epidemiologists can do. This is a nationwide ecological study. The manuscript is on writing. This was based on my collaboration. So as epidemiologist, I also serve as a consultant for the KPCPEN, Komite Pengendalian COVID dan Pemulihan Ekonomi Nasional. So I work with them, giving advice on vaccination, on and on booster consideration, and so on. And then based on those collaboration, we collected data on aggregated data actually on the COVID-19 incidence rate and also mortality rate per district, per kabupaten kota. And then we use other data that I mentioned before, like the indeks pembangunan manusia, kemudian indeks pembangunan kesehatan masyarakat, which are also available on district level. And then we we merge those data. So we merge those data, and then we then are available to do the nationwide ecological study to evaluate the association between the prevalence of comorbidity, the healthcare capacity. For example, they do have the data on how many for example, how many doctors, how many nurses, how many midwives that you have per 100,000 population for each district. They also have the data on the prevalence of hypertension, diabetes, obese, and also they have the data on population densities, numbers of health facilities, rumah sakit and puskesmas per district. That then you can simply assess, correlate with the COVID-19, for example, COVID-19 incidence rate or COVID-19 mortality rate, and then you can have like a simple linear regression or something like that. And the latest one, the other one is clinical characteristic and factor associated with COVID-19 hospitalization and mortality in 5 rural provinces in Indonesia. In this study, I collaborate with the PAIE, Perhimpunan Ahli Epidemiologi Indonesia, and also with the US CDC in Indonesia. So they have the project that they call as forgot the name. I forgot the name of the project, but they actually built a health information system that can then be used by the local epidemiologists at district health office to to enter the data, to enter the epidemiological investigation form, and then we use those data to study the clinical characteristic and also the risk factors associated with COVID-19 mortality and hospital admission. So again, a lot of opportunities that we can create on our own, and also opportunities that will automatically become yours because you have the expertise. Other people, statistician, biostatistician, mathematical modeler, they know statistics, they know mathematics, but they don't know about epidemiology. So they don't know how to properly collect data, analyze data, interpret data, and then use those data to to respond to the outbreaks or pandemic. So you have the knowledge and the skill. So the opportunities is yours. This is just to summarize the main challenges that we face. I've personally faced actually. One, when doing research and generating evidence, one, we really need to work on the quality of surveillance data. It has been issues or problems since long time ago actually. So the surveillance data are imperfect, not sempurna, tidak sempurna, but we still can use it to generate evidence. You can produce a high quality publication impact by using the data. The homework is just to how then to to improve the quality of surveillance data. Also, the limited access to data. These I think are on the government side. Because we as epidemiologists try to help to analyze the data, but then sometimes we don't have the access to the data. We try to collaborate with other provinces other than Jakarta, but then we fail to do it because they simply don't want to give us access to the data. So we cannot then help them. Third one is regarding funding. Limited local funding, support for epidemiological research. If you realize in the early phase of the pandemic, our government give money to support research on diagnostic, on developing, alat perlindungan diri (APD) and obat vaksin, but they don't invest, they don't provide funding to do simple epidemiological study. Although we know that epidemiological investigation is the key to, to control and respond to pandemic. So yeah, that's a pity. But then, especially, I hope if there is a government representative hearing this, they will then try to improve this. And the second one is around the policy making. I have to disclose this. This is just limited to my experience when working, dealing with. Working with some policymakers in both in like provincial and national level. I think I still find that the political will like to generate and use scientific evidence in formulating pandemic responses and public health intervention is it is there, the willingness is there, but then it's not supported by strong political will, strong funding, and strong system. So I think this is become a bigger project in a way, in a bigger scope for national policy makers. Summary of my talk will be: first, you know your role as epidemiologist, you know your skill set. So evidence showed that epidemiologists have played important roles in responding major health threats, including the current COVID-19 pandemic. From the John Snow's eras, how he did the field investigation door to door, how he did the mapping, he drew the map on the cases of cholera outbreak in London, and then how he then identified that cholera actually transmitted through the water, so it's waterborne diseases. And then how then he then generate the policy. The policy at that time is to to remove the pump handle to avoid further transmission of the diseases at the time. So from that era to now, where we try to develop any kind of public health intervention regarding COVID-19 pandemic, from vaccine, medicine, and also a simple social restriction. Regarding opportunities, I think as epidemiologists we are disease detectives, so with the necessary skills to collect, analyze, and interpret data, and also rapidly respond to the outbreaks, I think we epidemiologists will always become key players in responding at pandemics through research and also through control programs. Challenges, the key challenges will be ensuring the pandemic responses and public health intervention are actually based on scientific evidence generated from one, valid and reliable data, and two, robust study design and analysis. I think I will end my presentation, my talk, by acknowledging our collaborators from DKI Jakarta Health Office, the Conferences in Indonesia, Love for COVID-19, and also my team members at the crew and all healthcare workers involved in the care for the COVID-19 patient. I think thank you very much. I'm very welcome for discussion. Thank you, Pak Lukman. I will stop the share.
Yes, okay. Thank you very much, Henry, for informative and interesting lecture. And students, this time to you to ask the question, and we can start the discussion with Henry in 20 minutes. Okay, any one of you? Please raise your hand, or you can open your camera or write down in the chat. Is there any question?
Banyak ini partisipannya ini 156.
Okay, I will start from my question, Hen.
Yeah.
Your study said that mortality among children under 5 is high in Jakarta, right? But other findings show one of the risk factor is a comorbidity like hypertension, diabetes, and kidney chronic. Yeah. And it means children in Jakarta suffer from this comorbidity.
Okay, thank you. Well, actually, like I said before, that we don't really have the data on, especially for the children. Yeah, you are right. First, I have to clarify that that the COVID-19 mortality among under 5 children who were hospitalized, so di rumah sakit, were high during the early COVID-19 pandemic, and the discussion at the time is especially related to the critical health support for children, which was not truly available, or I can say that it is related to limited infrastructure because for under 5 children you cannot treat them similarly like the adults. So they have to have the specific equipment, they have to have specific specialists and something like that. And then in the early phase, because of people think that the risk of mortality are specific for those with comorbidities and also older people. I think there was delay actually on not only diagnosis but also potentially delay on getting help for children, because they think that they don't really they won't get high risk of mortality at the time anyway. But then again, but that was the result was from the hospitalized patient during the early pandemic of COVID-19. But then when we did the further analysis on the population level, so not only for the cases who were hospitalized but also for those who were not hospitalized, we then found out that the study confirmed that it is indeed high. The risk is high is higher for the under 5 years old during the early pandemic, but then it becomes lower during the second wave of the pandemics due to because we improve our case management are improved, and also we know more about the COVID-19. That means that the government actually successfully reduced the risk of COVID-19 mortality among under 5 years old children. But then again, I have to mention that other studies also, I think under Prof. Amin Subandrio group, I forgot the paper, but it was published. They also confirmed the quite high risk of mortality among under 5 years old children. And also because we don't have we have limited data on the condition of each children, so we don't really have the the data on the clinical prognosis. I can say that some of them had comorbidities, but some also not. So, but because of the small numbers of COVID-19 cases among under 5 years old children at the time, we were not able to to do like to stratify the analysis. So then it becomes inconclusive. But later on, we found out that the risk actually was not high in general population, so it's quite small, but then it's high among hospitalized patients during the early phase of the pandemic. Again, because of the reliance on the surveillance data, it can also means that under 5 years old children were underrepresented during the early COVID-19. They were not sent to the hospital because most of them will likely to have had mild symptoms or asymptomatic. That's why you only have like 60 or 70 cases. Then it makes your mortality rate or case fatality rate overestimated, karena denumeratornya kecil, harusnya kan masuk semua gitu ya. So that's I think the limitation of the study. Mudah-mudahan menjawab Pak Lukman.
Okay, siap. Okay, for the students, is there any question?
Ini malu-malu semua. Ini sudah student semua kah 150 ini? Banyak
Student semua.
Wow.
Ayo, mahasiswa tanya.
Atau kita yang tanya?
Ayo mahasiswa nanya, ayo. In bahasa boleh lah, gaduh-gaduh boleh lah.
Ini kayaknya ada yang ngomong tapi muted nih. Apa nih pada ngomong?
Oh iya, jangan lupa di open kameranya sama mic-nya. Ayo, siapa mau tanya?
Sebenarnya tadi ini kelihatan ngomong nih yang di depan saya. Siapa nih? Mar'atul Sarifah. Loh, hilang. Dit langsung mati videonya.
Kamu notice sih, Hen, jadi dia pergi, Hen.
Karena dia tadi kayak berbicara. Ini Assalamualaikum.
Di chat ini.
Wow.
The result of research from Oxford is that is the but what is your view on the follow-up
the judgments, because if the recommendation from the researchers are in okay. For example, at the beginning of the pandemic, there was a health minister from country X who seemed to reject this person. Okay, thank you. Yeah, thank you. Good question, actually. Well, actually, I cannot say that when I said that the political will to generate scientific evidence-based policy, I was talking about the greater thing, not specifically related to our study, but our study indeed, because the study were actually conducted by us by Oxford University, and also with the the provincial health office. Of course, they use the data to inform the policy. You know what I mean? Because we brought it together and then they presented to the Ministry of Health. And also my experience, because I was also involved in a 6-month consultation for the KP Japan. I also presented some of this finding, and also another finding regarding the effectiveness of booster using the Moderna one among healthcare workers. And then they actually acknowledge that we presented in front of the people from Ministry of Health, also the Itagi, the people who are, what you call it, Itagi is semacam yang apa sih, badan apa ya namanya Itagi, bahasa Indonesianya apa ya, asosiasi yang kemudian yang isinya adalah ahli-ahli imunisasi gitu, yang kemudian memberikan, bagaimana bahasa Indonesia, kemudian memberikan advisory committee on immunization lah, who are advising the government.
Technical advisory ya.
Yes, yes, regarding the vaccine rollout, also regarding the vaccine booster. At the time when we presented that our finding in front of Minister of Health, Itagi, and also people from Bio Farma and other, they acknowledge that, and actually I can confidently say that they actually use that as the basis for them. They have a combination of coronavirus, coronavac, or Sinovac plus then Moderna. At the time, they didn't do that study. They did the study, but for other combination. But our studies is for those combination, and then they use the evidence from our study actually to inform the policy making. So I cannot say that they don't actually take it, but that currently we don't have the environment that can support us as epidemiologists to generate the evidence, the robust evidence, to access the data, to access the funding, to help them, to help them to get information for guiding the public health policy formulation. I think that's what I can say. So they do follow it up. They did follow up.
Okay, thank you, Sylvie. Any further discussion from you? Sylvie, where are you?
No, Pak. Thank you.
Okay, thank you, Sylvie. Is there any question from other student? Putri Royan raise hand. Okay, please open the mic.
Okay, thank you, Mr. Lukman, for the opportunity. Assalamualaikum warahmatullahi wabarakatuh. My name is Putri Royan Tipa, and I'm from Universitas Negeri Semarang, and I'm majoring public health epidemiology. And firstly, I would like to appreciate Mr. Henry Surendra for giving such a great and interesting lecture. And secondly, I would like to ask some questions regarding to the 4 main goals of COVID-19 preparedness that you explained us before you explain your result of your research. And I read about it. There's a brief explanation about the first and second main goals, which is to suppress the transmission and to prevent the misinformation, respectively. And my question is, what do you think about when a country tend to face the misinformation problem first rather than the disease transmission first? Because in some cases, especially in Indonesia, when we face the problem, people tend to face such a big fuss about misinformation, harmful misinformation first, before even the first COVID-19 case confirmed. Yeah.
Thank you, Mbak Putri. Thank you. Such a great question, actually. Maybe Pak Lukman also can answer this, because at his opening stage, he said that during the pandemic, like everyone become epidemiologists, everyone freely spoke about about COVID-19 in social media, and yeah, maybe he can also say that. But I think true, it's true. It's become infodemic. I think the WHO call it as infodemic. That's why it's also important, to reduce the exposure, not only the virus exposure, but also exposure to misinformation. I think if we relate this to the title of the talk regarding the opportunities and challenges. This also can offer the opportunities for us. I think more epidemiologists should talk. I mean, the real epidemiologists should talk about it. Well, it's not necessarily in national media. I did that actually during the early COVID-19. I remember I think I did a live talk show interview 3 times in national television, and also maybe 50 to 60 times, online national media interview. I can't even remember that, but I did that during the early phase of the outbreak, even before we did our study actually. But then later on, it looks like a lot of people becomes expert, and then I myself disappear from the media. Then I just chose to focus on the research. You are right. You are true that especially in I think the impact of the misinformation itself is bigger, especially in the low and middle income countries like Indonesia. Especially Indonesia is quite diverse country with 514 districts, with many different level of what you call it, education, socio economic backgrounds. Then I think that we as epidemiologists cannot work alone in this manner. That's why, because I'm also, like I said to you, that I'm also involved in the KPCP, and I know that the Ministry of Health also work together with people from the John Hopkins University. I forgot the name. Research centers, something like that, in addressing, in assessing the impact of, how the social media, how the public figure speech impact the perception of community regarding COVID-19, regarding the vaccination and others. So, actually, that is also one of essential thing that cannot be done by ourselves as epidemiologists, but should be done in collaboration with others. And I think the government have done a good job in controlling that. Otherwise, even though that we cannot really control the social media, I mean, at least at least the national TV or the national media is I think it's still under control, because we've seen many experts talk about COVID-19, and I think even though we have some who are not really expert on the area, but I think it's still under control. So yeah, again, I'll give it back to you. Maybe Pak Lukman also want to add something. It is important. We cannot do it alone. We have to collaborate, and I think the government, I think the media is still under control, but the social media is just cannot be controlled, I think. Thank you.
Okay, thank you, Mr. Henry. Because this guest lecture topic is learn from the expert, so your answer is good enough.
Consider as expert, right?
Okay, Putri, is there any further discussion from you?
Thank you, Mr. Henry. That's such a great answer. Thank you.
Okay, thank you.
Welcome.
Other student, any question? 10 minutes left. Any question?
Masih punya 10 menit ya. Okay.
Hello guys. Any question? Okay, from me, Hen.
Yeah.
From your slide, continuing Putri's question, that risk communication is one of the pandemic preparedness. Based on your experience, what is the best way to educate effectively to the people who don't care about health, even they share about the hoax and etc.?
That's a tough question actually. Yeah. Well, I'm no expert on public engagement and communication, but I think I don't know the best way, because I don't know I don't know the best way, because I think it seems like now our government do many things. I mean, outside like the national campaigns, also the like decentralized campaigns. When I say decentralized, that I mean that the campaign that is being conducted by the district health office and also by the people under the puskesmas. So I think the best way to do it will be like to optimize the current health system that we have. For some countries, they don't have the system like what we have. The decentralization system is it can be it can be a limitation in one way, but it can also be the opportunities in another way. And I can see that the decentralization system, health system in Indonesia, can be an opportunity to actually build a strong public and community engagement in real time. You know what I mean? Because we have puskesmas, one district, sub-district may have 1 or 2 puskesmas, and then under the puskesmas we will have like bidan desa, we will have pustu, we have puskesmas keliling. I think simply by delivering information using those existing system will be the best approach that I think that can work in the setting like Indonesia. That other settings, they don't have this kind of system. We have this crazy system that we call it decentralized system. So I think, yeah, that's my best answer. You have to utilize that, but I think we don't really see that, right? We only see like maybe posters or campaigns in national TV, but we don't really see. I don't know. Have you guys seen people from puskesmas come to your house or come to Posyandu to give you, socialization during the COVID-19? I think you can answer it by yourself. Thank you.
Okay. Thank
Gimana
you.
Pak Lukman? Sudah politik sebelum jawaban saya.
Jawabannya cocok nih jadi
Systematic, right? I mean,
okay.
Yeah.
Ada pertanyaan lagi dari teman-teman semua? Silakan. Saya itu sebenarnya banyak pertanyaan ini karena dari yang disampaikan tadi oleh Pak Hendri itu penelitian low cost kan sebenarnya bisa gitu. Karena anak-anak teman-teman mahasiswa ini itu kan nyari ya mesti yang profitable gitu ya. Kalau bisa low cost, hasilnya bagus. Oh ya, sekarang itu di UNES itu lulus itu nggak pintu gerbangnya tidak harus dari skripsi, boleh publikasi. Itu
okay.
salah satu bisa, tapi kalau publikasinya di Sinta 3 sampai 6 harus diuji. Kalau Sinta 1, Sinta 2, Sinta 1 berarti kan Scopus ya. Kalau Sinta 2 berarti yang level tertingginya nasional itu tidak perlu diuji, langsung dapat A gitu. Jadi kan lumayan itu kalau misalnya menggunakan data yang low cost gitulah ya, seperti itu.
Iya.
Oke, teman-teman, ada yang mau ditanyakan? Mumpung ada ahlinya ini.
Ahli manipulasi data. No, in a good way. I mean, manipulating data kan in a good way.
Ya.
Data yang ada dipakai. Sebenarnya banyak sekali loh data Riskesdas, data Risfaskas itu banyak sekali yang bisa teman-teman pakai.
Termasuk yang level hanya kabupaten kota kan banyak data nganggur toh, nggak yang diolah gitu kan.
Betul, banyak benar.
Ada pertanyaan in bahasa boleh terakhir ini? Ini nggak ada kesempatan.
Boleh.
Berikutnya.
Saya jawab in bahasa juga ya. Nggak apa-apa kan?
Ini yang open kamera ada 2 ini. Mamlu Atul mau tanya?
Yes, sir. So actually, maybe my question is ordinary like the others, maybe, but this is one of the things that I think it's very important to us to know. It's about the data that underreporting, and I ever heard that Mr. Henry also said it in their presentation before about underreporting data, and I want to ask it in the COVID-19 cases. So that as we know that WHO ever said that the case of the mortality of COVID-19 in Indonesia is actually higher than what have been reported by our government. And I want to ask about that, sir. Actually, bagaimana pandangan Pak Henry about that, and is it also related with the asynchronous data from the local and from the national?
Yeah,
and
thank you.
how we can solve that, sir? Because this is the problem that have been terjadi selama bertahun-tahun, dan saya pikir itu juga masih terjadi sekarang begitu. Terima kasih Bapak.
Thank you. Ya, bahasa Indonesia ya. Oh,
ya. Boleh bahasa Indonesia.
Supaya ini ya. Sebenarnya memang betul sekali, selalu menjadi kemudian kelemahan di kita, karena kalau adik-adik, saya bilang adik-adik ya karena kita udah tua, coba buka aja laporan dari ada laporan, kan kita sebenarnya negara itu kan punya kewajiban yang di bawah WHO, punya kewajiban menjalankan yang namanya International Health Regulation ya, IHR 2005. Buka nanti ada dokumennya, International Health Regulation terkait dengan Global Health Security. Nah, di situ pernah ada joint external evaluation yang dilakukan WHO dan external partner untuk menilai seperti apa kualitas dari sistem respon kita lah di Indonesia. Dan di situ memang sudah ada dilaporkan bahwasannya memang kita selalu punya masalah terkait dengan surveillance ini, terkait dengan underreporting. Bukan hanya masalah dari pelaporan ya, pelaporan itu kita selalu punya masalah dengan ketidaktepatan waktu, ketidaklengkapan, dan lain-lain. Tapi juga kita kemudian pelaporan itu dipengaruhi dari ada tidaknya kasus. Nah, ada tidaknya kasus itu juga dipengaruhi dengan kemampuan kita kemudian melakukan diagnosis. Kemampuan diagnosis kita di Indonesia juga ternyata masih rendah. Jadi memang ini ada banyak sekali layernya. Kalau untuk memperbaiki underreporting ini tidak bisa bukan hanya pada level pelaporan, tapi juga pada level mulai dari berapa persen dari kasus itu yang missing dari deteksi dini sebenarnya. Dari kontak tracing itu berapa persen yang missing kasus yang harusnya ketemu, tapi katakan harusnya kita kontak tracing 1000 kontak dan mungkin kita akan menemukan 100 dari 1000, tapi kenyataannya mungkin hanya 500 yang tertracing, berarti udah hilang tuh di situ kasusnya. Ada kemungkinan hilang kasus 50, kemudian masuk dari sekian berapa persen sih yang kemudian dites, ada lagi kemungkinan hilang. Dari yang dites berapa persen sih yang dilaporkan, ada lagi kemungkinan hilang. Dari yang dilaporkan berapa persen yang akurat laporannya. Jadi memang layer ini tidak hanya di COVID-19, tapi di semua penyakit kita mengalami underreporting itu. Kebetulan kami juga sekarang sedang riset juga impact COVID terhadap program HIV, TB, dengue, dan juga imunisasi nasional, imunisasi pada anak bekerja sama dengan Kementerian Kesehatan di level nasional. Itu sama juga ketika kami lihat data 5 tahun terakhir, itu juga sama, memang masalahnya selalu masalah dengan di sistem kita ya, underreporting. Jadi sebenarnya untuk riset, masalah underreporting itu tidak bisa dihindari sebenarnya. Asalkan kita acknowledge, maka itu sah gitu. Tidak ada penelitian yang sempurna, yang ada adalah penelitian yang kemudian menyampaikan fakta dilakukan secara benar, sesuai dengan kaidah ilmiah dan etik, kemudian hasilnya begini. Peneliti itu boleh salah tapi nggak boleh bohong gitu ya. Jadi kita harus acknowledge memang ini kelemahannya begini, kelemahannya itu tadi imperfect, kan saya selalu bilang tadi imitasinya imperfect surveillance system, kemudian imperfect reporting, imperfect diagnosis, itu akan berakibat kepada tadi underestimating the total cases and probably overestimate justru mortality. Tapi kalau kaitannya dengan all cause mortality, memang itu beda lagi. All cause mortality itu adalah kematian secara umum tanpa kita bedakan penyebabnya, terlepas dari dia positif COVID apa tidak. Nah, memang benar laporan WHO itu menyatakan kalau hampir semua negara itu all cause mortality-nya memang lebih tinggi dari yang dilaporkan, karena di Indonesia memang tidak dilaporkan all cause mortality. Ya, saya tadi tidak menyampaikan kami sebenarnya melakukan excess death study juga, dan sudah ada preprintnya sebenarnya di Archive, di mana kita sudah menemukan tuh di awal-awal pandemi itu memang jauh dari yang dilaporkan kemungkinan kasusnya. Bagaimana kemudian menghandle untuk riset ya udah esidis gitu ya, laporkan, sampaikan apa adanya, faktanya, kelemahannya apa. Tapi kemudian bagaimana memperbaikinya, nah itu bukan di kita sih tempatnya. Memperbaiki itu tuh benar-benar sistematik sih, mulai dari pemerintah sampai ke bawah. Setuju, benar, dari bawah sampai ke atas itu, karena sistem reporting kita tadi decentralized ya. Jadi orang lapor dari puskesmas, kemudian masuk kabupaten kota, masuk provinsi, masuk nasional. Jadi memang sangat kompleks. Mungkin itu ya respon dari saya, Mbak. Terima kasih. Hebat pertanyaannya.
Oke, pertanyaannya surveillance banget itu ya. Ini tadi yang saya petik dari yang disampaikan Pak Hendri adalah yang penting acknowledge kalau ada kekurangan ya gitu ya. Jadi kadang mahasiswa itu kalau menulis skripsi itu kadang insecure duluan. Waduh, penelitian saya, skripsi saya kira-kira dihajar nggak nih pas ujian nanti ini kayak gitu. Kadang-kadang seperti itu gitu. Padahal sebenarnya kan semua sisi penelitian tidak ada yang sempurna. Begitu ya kurang lebih ya Pak Henry ya.
Betul, betul, betul. Yang terakhir itu bahkan kami ada yang missing sampai 50%, tapi keterima tuh di BMJ Global Health. Sebelumnya 40% di Lancet Regional Health juga diterima. Karena kita acknowledge dan kita sudah sampaikan ini upaya apa yang sudah kita lakukan untuk handle bias. Jadi nggak masalah gitu.
Nah, tuh. Bisa jadi pelajaran ya. Jadi missing data sampai 50% pun keluar di Lancet itu ya. Apalagi cuman keluar di Sinta 2 itu yang penting di-acknowledge gitu ya. Jadi tadi yang disampaikan penelitian itu tidak boleh ngapusi ya, tapi harus boleh salah tapi nggak boleh ngapusi gitu. Silakan ada lagi sebelum ditutup closing statement dari beliau, teman-teman. Jadi beliau ini salah satu kepakarannya di malaria. Mungkin belum banyak ya penelitian skripsi kita tentang malaria karena areanya memang tertentu ya. Di Kota Semarang sepertinya kok tidak ada gitu. Jadi kayaknya harus ke Banjarnegara mungkin ya terdekat itu. Teman-teman di sini pun banyak yang ada yang berasal dari Banjarnegara juga, bisa dimanfaatkan betul itu. Nanti mungkin bisa sharing dengan beliau tentang kemalariaan ya, seperti apa. Sudah tidak ada lagi. Sebelum saya tutup, saya ingin menyampaikan tentang, sebentar saya share screen dulu. Share tentang ini ya. Mana sih? Guys, it is the e-certificate issuance link. You can click with this link s.id/ph2022-1. Please write your email address correctly and the e-certificate will be sent to your email address. Make sure that your email address is correct. And the link is active for only 60 minutes after this lecture is over. Okay, you can write down the link now. Okay, I will rewrite again in the chat to you can click directly. Okay, finally we come to the end of our session of the class. I would like to say thanks again for Mr. Henry, Dr. Henry, for the interesting talk. And let's give once again a big round of applause for him. Thank you very much, Henry. And hopefully the lecture will be beneficial for everybody. Okay, before we leave, take picture together. Please open the camera.
Ini yang paling penting.
Yes, betul sekali. Ini yang harus dilaporkan ke bagian si bos ini, yang penting. Okay, open the camera. Screen 1. Open the camera, please. Okay, 1 and 2 and 3. Screen number 2. Please open the camera. 1, 2, 3. Number 3. 1 and 2 and 3. Okay, thank you Henry for your time and bisa ketemu lagi kapan ini ya?
Undang lagi nggak?
Lagi. Oh boleh, siap. Undang lagi nanti. Kopi darat aja.
Yeah, I can speak about zoonotic malaria or malaria.
Okay, before we get we go to the closing, silakan Hen, closing statement Hen. Sebelum ditutup.
Oh masih ada.
Terakhir lah, closing statement lah. Menyemangati anak-anak ini untuk riset, untuk riset yang bisa ya lokos gitulah ya. Gitu.
Iya, saya kira tadi sebenarnya ya terima kasih ya atas kesempatannya ya Pak Lukman dan teman-teman semua. Saya kira tadi ya kalau kita balik ke basicnya, teman-teman harus, adik-adik itu harus memegang kuat basic science dari epidemiologi itu kan selalu tentang OTW ya, orang, tempat, waktu gitu ya. orang, siapa itu yang kena suatu masalah kesehatan, tempatnya di mana, lokasinya di mana, secara spasial, kemudian waktunya kapan gitu. Dan kemudian kita menggunakan informasi itu untuk melakukan pencegahan, yang mengaplikasikan untuk memecahkan atau mengatasi permasalahan kesehatan tersebut. Nah, teman-teman kalau ingat itu terus, insya Allah kuat di situ akan gampang sekali kemudian nanti menerapkan ilmu epidemiologi di penyakit apapun atau masalah kesehatan apapun. Nah, yang kedua, tadi saya bilang kalau kaitannya dengan penyakit menular, maka epidemiologis itu adalah disease detectives ya, seperti Conan itu ya, Edogawa tadi ya, detektif penyakit gitu, yang kita punya skill untuk bagaimana kita mengkoleksi data, menganalisis, menginterpretasi, dan bagaimana kemudian kita juga menggunakan informasi tersebut untuk merespon suatu wabah, KLB atau pandemi ya sekalipun. Jadi epidemiolog, teman-teman, kita ini akan selalu menjadi pemain kunci gitu ya, pemain kunci dalam mengatasi masalah-masalah kesehatan, terutama yang berpotensi untuk menimbulkan KLB, pandemik atau masalah global health security gitu. Dan tadi yang terakhir mungkin saya ingatkan lagi adalah tantangan kita memang kita bisa menghasilkan penelitian-penelitian yang low cost dengan memanfaatkan data-data yang ada, hanya saja kita perlu kemudian mencari tahu nih bagaimana caranya untuk mencari tahu kelemahannya dan bagaimana cara mengatasi kelemahannya. Saya kira itu saja kalau dari saya, Pak Lukman, saya kembalikan. Terima kasih banyak. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Terima kasih Pak Hendri atas waktunya. Sukses selalu. Semoga kegiatannya di Medan lancar. Oke. Terima kasih semuanya. Mahasiswa juga terima kasih.
Pamit ya.
Ya, makasih Hen. Link sertifikatnya saya tulis di chat ya. Siapa tahu tadi belum diketik. Lumayan lah, dapat 1 seri sertifikat kan bisa nambah CV ya. Apalagi dapat 4 gitu ya. Apalagi setiap kuliah ada sertifikat, jadi ada 20 sekian sertifikat ya. Kuliahnya banyak soalnya. Oke, sebelum saya tutup, untuk teman-teman yang semester 4 yang mungkin mau peminatan dan yang sudah semester 6 EPID, saya hanya meng-highlight tadi yang disampaikan oleh Pak Hendri, bahwa penelitian low cost itu bisa, bahkan kadang validity-nya lebih bagus dari penelitian yang kita, sebentar, low cost itu berarti ambil datanya orang ya. Low cost itu berarti ambil secondary data dari Dinkes, rumah sakit, sampai level yang naik ya, Dinkes Prof, level rumah sakit seprovinsi. Tadi kan Hendri itu penelitiannya level rumah sakit se-Jakarta, se-DKI Jakarta provinsi semuanya. Sekota kabupaten semuanya di Jakarta. Atau naik lagi level nasional. Jadi bisa jadi penelitiannya murah, hanya ambil data itu, yang penting koordinasinya bagus. Kalau di Riskesdas saya pernah ambil data itu cuma bayar 300 kalau nggak salah. Itu semua data. Yang kita minta tidak bayarnya per sampel ya. 1 sheet data, misalnya faktor risiko stroke, 1 sheet data, ada faktor risikonya 10, 15, bayarnya 300.000. Selesai. Itu bisa jadi validity-nya lebih bagus daripada kita ambil data primer ke lapangan ambil data primer ke lapangan pakai kuesioner, mungkin kita sebagai peneliti enumnya ada bias wawancara, bias responden, dan bias-bias yang lain. Dan kadang mungkin instrumen kuesioner kita mungkin validity-nya dipertanyakan seperti itu. Jadi ini pernah saya mulai kenalkan data sekunder ini saya masih ingat namanya senior kalian, angkatan berapa itu, Nida sama Mbak Nimas. Mereka berdua mau magang ke Kemenkes. Pak, saya harus ngapain ya Pak? Nyari akses data sekunder. Coba skripsian nanti setelah PKL-an magang pakai data itu. Apa boleh Pak? Di sini kan belum umum. Gitu. Akhirnya Nida maju sama Mbak Nimas ini, Mbak Nida, Mbak Nimas maju. Yang saya dengar statement pertama adalah dari seorang penguji bilang, "Lah kok enak pakai data sekunder?" Gitu. Padahal penelitian seperti itu kan sudah umum sekali. Buktinya tadi Pak Hendri publikasi di jurnal Lancet, tahu sendiri ya. Lancet itu adalah nomor satunya jurnal ya, public health itu. Itu missing value-nya sampai 50%, itu diterima loh gitu. Apalagi yang hanya dalam tanda kutip level skripsi yang UNES, Sinta yang Sinta 2, 3, 4, 5, 6 dan seterusnya. Jadi akhirnya setelah itu walaupun dengan 2 orang ini sepertinya membabat alas gitu ya, membuka lahan betul biar adik-adiknya bisa ngajuin secondary data tanpa adanya tanpa adanya ya di underestimate lah oleh penguji seperti itu. Jadi sudah enak di zaman kalian karena sudah dibuka lahannya oleh 2 senior ini. Dan 2 senior ini lulus dengan menggunakan data sekunder. Bahkan kalau nggak salah si Mbak Nida ini publikasi di jurnal Epidemiologi Asia apa ya kalau nggak salah. Gitu. Dia tuh berskopus juga. Begitu ya, yang semester 6 sebentar lagi PKL manfaatkan betul tempat PKL kalian dengan data sekundernya yang nganggur. Karena saya jamin data sekunder itu mesti dibiarkan tidak diolah, belum diolah. Tugasnya kalian yang analyze orang, tempat, waktu tadi yang disampaikan. Begitu ya. Ini dari saya cukup. Terima kasih atas waktunya. Jangan lupa masih ada 3 seri selanjutnya. Nanti siang jam berapa ya? Jam 2:30 itu tentang how to publish article in index journal. Ini juga penting juga ya. Kalian yang mau ambil mazhab publikasi bisa belajar dari situ. Siapa tahu nggak mau ambil mazhab yang nulis skripsi ya. Nulis skripsi 150 halaman, Pak. Nulis publikasi kan cuma 10 halaman, Pak. Nah, itu silahkan banyak belajar betul dari nanti sore ya, betul, siang sore. Terus besok ada Prof. Syabir tentang artificial intelligence. Siapa tahu mau buat aplikasi tentang kecerdasan buatan. Masuk yang artificial intelligence paling simpel kan kalau kita masuk ruangan ada kamera yang mendeteksi suhu tubuh kita ya. Itu yang paling simpel itu. Yang paling simpel, yang pakai kamera itu loh. Jadi langsung keluar bunyi notifikasi dan sebagainya. Terus hari Jumat ada kelas dengan Profesor Sulaiman tentang GIS. Siapa tahu mau penelitian data sekunder tentang kewilayahan, iklim, land use, kemudian cuaca dan sebagainya kan banyak nganggur juga di BMKG dan sebagainya. Itu bisa dikaitkan dengan kejadian penyakit leptospirosis yang berbau dengan lingkungan ya, yang environmental borne ya. Leptospirosis, kemudian bisa juga dengue, cikungunya. Yang anak-anak teman-teman keseling juga bisa tune in juga di sini. Semester 4 persiapan untuk nulis skripsi juga bisa juga bergabung di sini. Oke, terima kasih dari saya. Saya cukupkan. Mohon maaf atas segala kekurangannya. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Terima kasih